This is a video for Chapter 25, Drugs for Dysrhythmias. So we're going to talk about the electrical conduction through the heart and what that looks like on an EKG or an electrocardiogram. What I'm showing you here is a dysrhythmia. This is the most common type of arrhythmia or dysrhythmia that you will come across and see. This is what atrial fibrillation looks like. So we've talked about atrial fibrillation and where the atria fibrillate and where they tend to pool blood, and that's what can increase someone's risk for stroke or heart attack. And this is what it actually looks like. And I'll go through kind of how I am determining that to some point. It's a little advanced for you right now, but this is what a true abnormal rhythm looks like. And it's stemming from the atria. So we can classify dysrhythmias by location. So if it's atrial or ventricular, so for example, that was atrial fibrillation, or by type of rhythm abnormality. So it can be flutter, which is more of a kind of symmetric abnormality. It looks more like a sawtooth pattern in the atria. We can have fibrillation, which is not really, there's no real pattern to it, and there could be heart block. There's different degrees of heart block, first, second, and third degree, or complete heart block, which means that there's no communication, no synchronization between the atria and the ventricles, so the heart's not able to pump adequately, and usually that's when the client would need a pacemaker. So we'll go through this. This is what's happening. This is a relationship between the electrocardiogram and the electrical conduction through the heart. So what happens is the SA node is the pacemaker of the heart. So the electrical impulse travels from the SA node down through the AV node, through the bundle of His, and down to the Purkinje fibers, and which in turn allows the heart to pump. So when the impulse is traveling down through the AV node, then that causes atrial depolarization, and you will see it as a P wave on the electrocardiogram. As the impulse travels down through the bundle of His and Purkinje fibers, that is the ventricular depolarization, and that communicates on the electrocardiogram as the QRS wave. As the ventricles repolarize, we see that on the electrocardiogram as the T wave. With that being said, just because there is electrical activity in the heart does not necessarily mean that the heart is pumping. So we could see this on the monitor, especially in a code situation. There could be many different reasons why this occurs, but just because there is a rhythm up on the monitor and the heart is producing this electrical activity does not necessarily mean that the heart is actually pumping. So we need to check for a pulse. And if that's the case, where we see a rhythm but there's no pulse, it's called pulseless electrical activity. So we have to remember that fact, that there's kind of two different things going on here. We have to have the electrical activity, but we also have to have the heart actually pumping out the blood. The myocardial action potential is referring to the changes in the sodium and potassium levels, and these generate the action potential in the myocardial cells. Depolarization occurs when sodium and calcium rushes in, and repolarization occurs when potassium is moved out. So then the primary mechanisms of action of antidysrhythmic drugs is, one of them is to block these flow of ions. The other is to alter automaticity. So automaticity is when we refer to the SA node. The SA node can work all by itself. It doesn't need any autonomic control by the autonomic nervous system. It can release this electrical impulse all by itself, the SA node, because it's called the pacemaker of the heart. A therapeutic action, of course, of antidysrhythmic drugs is to correct the dysrhythmia that's going on. So there's 5 groups. There's sodium channel blockers, which is class 1, beta blockers again, which is class 2. We see these beta blockers popping up in all different subject areas that we're talking about with the heart. Potassium channel blockers, class 3, calcium channel blockers again, class 4, and then some miscellaneous antidysrhythmic drugs. So class 1, they block sodium ion channels and suppress ectopic activity. So ectopic activity means that there's electrical activity coming from another area in the heart. It could be coming from an area of the atria or an area of the ventricle, and it's not coming from the SA node. So then this can cause dysrhythmias, maybe a really high, fast heart rate or a really low heart rate. And we don't want that to happen. We want the electrical activity to come from the SA node for many different reasons. Class 2 or beta blocker medications, they slow the heart rate, which we know. They decrease the conduction velocity through the AV node, which we haven't talked about too much just yet. Class 3, so these are potassium channel blockers. They delay repolarization and they lengthen the refractory period. So they kind of slow things down and they stabilize the dysrhythmia. Class 4, again, calcium channel blockers. They popped up again here. They reduce the automaticity in the SA node and slows the impulse conduction through the AV node, slowing the heart rate. So if a really fast heart rate's going on, then we might want to use this calcium channel blocker. There are some miscellaneous antidysrhythmic drugs. They slow the conduction through the AV node and or decrease the automaticity of the SA node. But a caution that all dysrhythmic agents have the potential to cause new dysrhythmias or worsen the existing dysrhythmia. So it's a fine line that we're walking. This is from your book, and the first one we're going to talk about is procainamide, which is a sodium channel blocker. So it blocks sodium ion channels, which slows rate and impulse conduction across the heart. It's used to correct many different types of atrial and ventricular dysrhythmias. Adverse effects are hypotension, GI effects, headache, and lupus-like syndrome. The role of the nurse with sodium channel blockers is to monitor for these ECG or EKG changes, monitor for hypotension, changes in level of consciousness, and diarrhea. We want to teach our clients to take medication as directed and to avoid alcohol. And it's contraindicated when clients have heart failure or renal impairment. The next one I want to talk about is the beta blocker propranolol. So this beta blocker blocks beta 1 and beta 2 receptors, so it's non-selective. This results in slowing the heart rate and conduction velocity and also decreases contractility and lowering blood pressure. Treats dysrhythmias, tachycardia, hypertension, angina, migraine, headaches, and prevents MI. In adverse effects can be hypotension, fatigue, bradycardia, and diminished libido. And probably also something that's missing up there, because it also blocks beta 2 receptors, it can act on the lungs and cause bronchoconstriction. So role of the nurse is contraindicated in clients with heart block, severe bradycardia, AV block, and then there it is, asthma and COPD, because of that risk of causing bronchoconstriction. Monitor for hypotension and hypoglycemia. Elderly clients may show signs of cognitive impairment, and we want to teach our clients to measure their heart rate, to rise slowly because of this lower blood pressure, and to report signs of heart failure because of that decreased contractility. Potassium channel blockers, the prototype drug is amiodarone. They block potassium ion channels in myocardial cells. They're used primarily to treat resistant ventricular tachycardia and also atrial dysrhythmias. Adverse effects are hypotension, pneumonia-like syndrome, blurred vision, rashes, photosensitivity, GI effects, fatigue, and dizziness. Role of the nurse for potassium channel blockers. We want to use cautiously in clients with heart block. We want to monitor for vision changes, palpitations, jaundice, abdominal pain. And for these, we want them to avoid sun exposure because it makes their photosensitive kind of medications, and also for them to take with food. Verapamil is a prototype drug for calcium channel blockers for dysrhythmias. They inhibit the flow of calcium into cells, they slow conduction velocity, and stabilizes dysrhythmias. They are used primarily to treat supraventricular tachycardia. We also call that SVT. Supraventricular tachycardia can cause someone to have a heart rate upwards of 200 beats per minute. So this is a medical emergency. They do not feel well. We need to get that heart rate down because that blood is just pooling. It's not going to be able to, the myocardium is not able to properly pump out all of the blood out of the heart. So we want to treat that as soon as we can. Adverse effects are hypotension, headache, and constipation. Role of the nurse in calcium channel blockers. We do not want to use them for clients with heart block, severe hypotension, cardiogenic shock, and heart failure. As in the previous video, they are not even one of the drug classes that are used to treat heart failure. We want them to report palpitations, edema, shortness of breath, and again, we don't want them to take calcium channel blockers with grapefruit juice because it increases the serum concentration of the drug, which can lead to toxic effects. So there's no specific dysrhythmia medication that I really want you to focus on. But again, you need to know all of the different drug classes and to be familiar with them. And that is it for this video.